Good morning, everyone. So, I will present this talk on strategies to avert or delay liver transplantation in biliary atresia. So, the strategies which I will discuss will be Kasai, steroids, cholangitis, adjuvant therapies, about few words about portal hypertension. But before this, we have to understand the natural history and long-term outcome of biliary atresia post Kasai. So, what is the natural history? So, before this, we should understand that how do we define the success of a Kasai potoenterostomy. So Kasai potoenterostomy is defined as when the bilirubin becomes less than 2 in 6 months or 3 months after a Kasai surgery, and other parameters which are also included are rate of decline of bilirubin, longer duration of jaundice, or delayed clearance of jaundice. That also is used to define success of Kasai potoenterostomy. So, short term survival with native liver depends on various factors, like some are modifiable, others are non modifiable. Not going into the details of this, but I will just come to briefly about the natural history post Kasai. So, after a Kasai potoenterostomy in biliary atresia, the outcome may be the patient may have may be unsuccessful, that is the bilirubin is high, they may have rapid decomposition, portal hypertension, variceal bleed, infections, and they need early transplant within infancy. Then successful transplant again may have two different kinds of outcomes, like they may have recurrent cholangitis, portal hypertension, decompensation, and again they may need transplant either 1 to 2 years, or even it may be delayed. Then other group is in the successful Kasai potoenterostomy is infrequent cholangitis, where we have slow portal hypertension, and around 20% may survive into adulthood with their native liver. So this is a busy slide, but just to highlight that successful Kasai potoenterostomy again, as mentioned earlier, they may have recurrent cholangitis, or a severe or refractory cholangitis even can lead to outcome which may be poor in terms of infections or need of early liver transplant. And then the last one is infrequent or no cholangitis, when they may survive into adulthood. The proportion is around 20 to 30%. So, what are the events in the long term after a successful Kasai potoenterostomy? So, these are the events. These are cholangitis, variceal bleed, portal hypertension, pulmonary complications like hepatopulmonary syndrome, portopulmonary hypertension, and decompensation. So this is the list of various indications for liver transplantation in biliary atresia. Either it is a completely failed Kasai or recurrent cholangitis. There may be growth failure, complications of portal hypertension, refractory variceal bleed, or pulmonary complications, hepatorenal syndrome. So, but not a single indication, like isolated portal hypertension especially should not be considered as a single indication for liver transplantation in biliary atresia. So a combination, a patient should be seen in totality for listing for liver transplant. So, these are various studies where they mentioned that what is the long-term survival, 5 to 25 years after a Kasai. Survival with native liver varies from 23 to 76%. Cholangitis is there even in late after in the second in the at the end of the first decade or second decade. Portal hypertension is almost universal, 33 to 95%. So most of these patients, when they reach adolescent or adulthood, they are cirrhotic. So they around 50 to 90% to 97% they have a cirrhotic liver. Hepatolithiasis may also be seen, and some may have typically secondary sclerosing cholangitis. So overall, just 1 in 4 or 5 cases become long-term survivors with good physical and mental development. And various predictors of long-term survival are, again, the initial, if there is biliary flow, or if there is cholangitis, age at Kasai. Again, these are the predictors for long-term survival. So various indications, if we see the different age groups, so what are the indications in infancy? Indications are persistent jaundice, unsuccessful Kasai, or cholangitis. But if we go towards adolescent, so then the indications relatively change. It is more of portal hypertension, pulmonary complications, and also late cholangitis. So prognostic marker, this is a study from King's where they mentioned that beyond 16 years of age, if there is late cholangitis, portal hypertension, or varices, so then there is need of liver transplantation. So in the absence of jaundice, again portal hypertension is an important indication for transplantation in biliary atresia. So again, this study from King's, they mentioned that cholangitis and varices, so how the outcome is different in terms of need for liver transplantation. So from King's, they also looked for Mayo-PSC score. So primary sclerosing cholangitis is one of the disease which is considered as an adult equivalent of biliary atresia. So they looked up and they mentioned that Mayo PSC score has a very good predictability for need for liver transplantation. Pulmonary complications. So this is ILPS data where we actually studied biliary atresia infants, and we found that, and older children also. So the prevalence of biliary of hepatopulmonary syndrome was around 57% at a median age at diagnosis of around 14 months. And at follow-up, this prevalence of HPS increased further to 74% at a rate of 0.7% per month. So subsequently, if they are transplanted, if they have severe HPS, they have delayed extubation, and also they have poor outcome. Portopulmonary hypertension also has been mentioned up to the rate of around 5%. So I am proposing here various strategies. So we can learn these strategies as 9 points or 9 sutras, so which are strategic by the mnemonic strategic. So going one by one. So briefly, so first is go for Kasai, not for primary liver transplantation, but we have to carefully look up for the need for liver transplantation after a Kasai potrantostomy. So why not primary liver transplant? Because under 1 year of age, there is high mortality, which is 2 to 3 times higher than the older age groups. Again, this is data from ELTR database, where they mentioned that under 1 year of age, the transplant rate is around, the success is 85% in comparison to 3 to 15 years, where the success is 94%. Primary liver transplantation has been increasing worldwide. So, this compilation of these studies mentioned that it is around 3 to 10% for biliary atresia. And this is a study which mentioned that primary liver transplantation versus salvage, which they mention as after a Kasai potrantostomy when they did the liver transplantation. Here they mentioned that hazard rate for mortality after salvage liver transplantation was high. So, but there are caveats. So again, this is another study which mentioned that after a Kasai potrantostomy, there is more risk of infections. They mentioned that there are more adhesions, but the caveat here is this is a Markov model analysis, cost effectiveness. In this model, they mention cost of Kasai, cost of liver transplantation, monthly cost, need of retransplant, and probability of mortality after a retransplant. So they mentioned that there was an incremental cost-effective ratio for primary liver transplantation was around $18 lakh higher than a Kasai potrantostomy. Even if you consider 100% graft and patient survival, then also the Kasai potrantostomy was more cost effective. So if we consider primary liver transplantation, the demerits are that these patients are younger, so they have more technical issues, surgical related issues, more risk of hepatic artery thrombosis, portal vein thrombosis, and there is need of reduced and hyper reduced grafts. So this needs more technical expertise, and also because they remain on immunosuppression for a longer period of time. So there is, and their EBV, the serology is negative. So they have more risk of EBV infection after transplant. So there is risk of PTLD, metabolic syndrome, and also theoretically there may be risk of, because of longer immunosuppression, they have more risk of renal dysfunction. So about ACLF also, this is acute on chronic liver failure as per the EASL definition as well as APASL definition. So as per EASL definition, they consider even biliary atresia as the cause of ACLF in children, and they mentioned that this may be seen in around 20% of the patients with a very high waitlist mortality. So higher PELT is associated with higher morbidity as indicated in this study. So what should we do after a Kasai potrantostomy? We should look for their growth, careful surveillance for cholangitis, variceal screening for portal hypertension, Dopplers for portal vein, Harry and bile lakes, and vaccination should be up to date. And also we should screen for hepatopulmonary syndrome as indicated by the study from ILBS. So next point is we should start steroids by day 7 if there is no evidence of infection. So theoretical basis is there is inflammation in the region of the porta because there is Roux loop which is directly connected to the porta. So there is inflammation, and so to suppress this inflammation, so the studies have shown that there are raised inflammatory markers, IL-2, interferon gamma, and various adhesion molecules which are high, and these high adhesion molecules, they are associated with poor outcome. 2 randomized control trials, they have shown for usage of steroids that there was no difference in outcome in survival with natal liver at 1 year or 2 years. But when this study from Devonport, when they compared the under 70 day age group, so the steroids were more effective. Devonport also showed that when high dose steroids was given, there was a slightly improved survival in comparison to low dose steroids. So this is an interesting concept which is budesonide. So we are afraid of giving oral steroids in biliary atresia because of risk of infection, cholangitis. But from Germany, this study used rectal budesonide foam enema daily for 3 months after Kasai potentoscopy and compared with 81 historic controls. And they mentioned that the survival with native liver was 54% versus 32%. So this study indicated that there was difference in comparison to the oral steroid study where there was no difference in survival with native liver. So next thing is we should tackle cholangitis. We should look for cholangitis and tackle it hard. So cholangitis, as we know, so this is common. I will skip this. So there is dysbiosis in biliary atresia. There is decrease in the good bacteria and increase in the bad bacteria. And this study has shown that cultures are usually not positive. But if we look up the bacterial DNA in the serum, so this DNA may be positive. This is the study from China. So prophylactic antibiotics, what is the role? So this is just a single randomized controlled trial and this is a very small study, 19 patients versus 20 patients, but they mentioned that there was lower recurrence of cholangitis and better survival in the treatment group. But there is no uniform protocol on what is the duration of antibiotics, what is the choice of antibiotics, and what is the pattern. Should it be given continuous or cyclic? At ILBS, what we follow is we use cefixime with ofloxacin or Septran, which is alternated every 3 to 4 weeks, and this is continued for a minimum of 1 year after Kasai or 1 year after the last episode of cholangitis. So this is another trial from China where post-operatively they divided groups into receiving either one week antibiotic or 14 days antibiotic. So 7 days versus 14 days was compared, but the cholangitis incidence was comparable. Early cholangitis, that is within 1 month, was lesser with the longer course, and average number of episodes were also lesser with a longer course of IV antibiotics. So this is data from ILBS that we also studied. This was unpublished, but the incidence of cholangitis when it is more than even a single episode, so one or more episodes, so that's a single episode can lead to poor survival with native liver. So this was a published work from ILBS where there was 20 patients who were listed for liver transplantation. Portal hypertension was there in 12 of them. 7 had bile lakes or cholangitis abscess. So prolonged IV antibiotics, home intravenous IV antibiotics, this concept we took from a Korean study where the median duration we used for almost around 58 days. So this was a very longer IV antibiotic usage. 7 also underwent aspirations and 4 underwent PTBD. Cultures were also positive. So at follow-up, so 14 out of 20 were delisted and they became jaundice free. And on the other hand, 2 of the 5 who were transplanted, they died because of post-liver transplant sepsis, and 1 died awaiting liver transplantation. So what about cholangitis? The cholangitis, the definition is not still clear. So this is a recent Delphi consensus for cholangitis in biliary atresia. So they looked up various elements like clinical, laboratory, and imaging diagnosis and other things and markers. At ILBS, what we follow is we do not just stick on jaundice fever or ecolic stools. We look for fever plus minus ecolic stools with recurrence or rising bilirubin, which initial fall by around 50%. And procalcitonin and blood culture again are not reliable. So we start on piperacillin tazobactam, change to and look for the bilirubin every 3 to 4 days. Continue with the same antibiotic if bilirubin comes down, but if it is static or rising bilirubin, we change to IV meropenem, and then there are other protocols, usage of other antibiotics like ceftriaxone EDTA, that is Eloris, colistin tigecycline, or even Zavicefta, which we are using now recently. And if there is no response in 2 to 4 weeks, then we label as refractory cholangitis. And at the same time, we continue with the cyclic antibiotics. We list for liver transplantation when there is persistently high bilirubin, evidence of portal hypertension, decompensation, or if there is evidence of hepatobiliary syndrome, particularly if it is moderate HPS. So this is a scenario. So this was a child who was diagnosed as cystic variant of biliary atresia outside, and he came to us with a recurrent episodes of cholangitis. So repeated episodes of cholangitis, and on evaluation her bilirubin was high, multiple echogenic intrahepatic cysts. So there was gross dilatation of the IHBRD. So these were typical bile lakes. And so she was taken up for PTBD. An option of liver transplantation was given, but she was taken up for PTBD. The dilatation was done, and the bile actually this. So this is the picture of the bile. So there was the bile was full of stones. So this was hepatolithiasis. The tract was subsequently dilated, and following dilatation, subsequently the PTBD catheter was removed. And on follow-up, the bilirubin came down to 4.4 to 1.1, and almost around 3.5 years post this intervention, so she is surviving with her native liver. So next scenario, so this is a child from Indonesia who came to us, who had portal hypertension, large varices, but he came at 17 years. He came with fever, with jaundice, with massive splenomegaly. So he already had portal hypertension, MELD was high, fibroscan was 75. So this is the picture of his MRCP, full of bile lakes, and also the stone we can see in the cut section, the stone up to the size of 10.5. So here there was not much doubt that this child does not need liver transplantation. So bilirubin was high, but with IV antibiotics, again it came down to 3.2. So, but although other indications were there, so that's why he was transplanted within 2 months of presentation. So next is usage of antivirals for CMV associated biliary atresia. So CMV associated biliary atresia has been mentioned in various studies. So the first work was done from King's, and the prevalence of CMV in association with biliary atresia is around 10 to 32%. So this study is a large cohort from US, published last year, where they mentioned that CMV positivity is associated with poor survival with native liver, and this is irrespective of age at the time of Kasai, whether it was less than 30 days, 30 to 60 days, or more than 60 days. What about usage of antivirals? So Davenport had used antivirals for IgM or CMV PCR positive patients, and he had shown that 8 of the patients who were treated with antivirals versus 28 who were not, so they had higher clearance of jaundice, better survival with native liver, but comparable overall survival. So there is still a chance of curing CMV when it is associated with biliary atresia, and they may have slightly better outcome. Next is endoscopy. By around 6 to 9 months of age, we should be very vigilant for to look these children for development of portal hypertension. Portal hypertension, as we know, so as the age progresses, the prevalence of portal hypertension increases, and there is some connection with of portal hypertension with cholangitis. And the portal hypertension, this I already mentioned, that even in the absence of jaundice, this may be an indication. And bilirubin, as the bilirubin increases, the prevalence of portal hypertension increases. Variceal bleed increases. This is more seen when there are gastric varices or presence of red color signs in biliary atresia. So these are various series. So variceal bleed risk is around 20 to 35%, and this is associated with large esophageal varices or gastric varices. What about portal vein sclerosis? So portal vein sclerosis is when the portal vein size is less than 4 mm, and various studies have shown that this is associated with poor native liver survival and also need of portal venoplasty. So this is a study where they compared the biliary atresia explants in comparison to the explants from other disorders in children. So there was significant intimal hyperplasia of the portal vein in the biliary atresia explants. And also there is hepatic artery. As the portal vein shrinks, the hepatic artery becomes more, the hepatic artery resistive index increases. So HARI has been shown that HARI more than equal to 1 is associated with worse liver functions and also risk of death and need for liver transplantation. So this is a child who is currently admitted with us for last around 1.5 months. Jaundice with pale stools, operated outside. So she had almost a partially successful Kasai with a bilirubin came down to around 4. So then she presented with recurrence of jaundice and with refractory ascites. So she came at around 9 months, around 8 months of age with splenomegaly, refractory ascites, and this is what actually happened. Refractory ascites requiring diuretics, upper GI showing grade 2 varices, and AST-ALT at one point of time went to thousands. Portal vein was sluggish flow, hepatofugal flow, and even the hepatic artery resistive index lead to a reversal of flow. So that indicated that there was some ischemia which was going on in her liver. So portal sclerosis, this I already mentioned. We also looked up and we found a cutoff of around 5 mm, which was associated with poor native liver survival. So this is a data which is under publication. Colopathy in biliary atresia. In 29 children, we looked up. Severe colopathy was found in 65%, and this was predicted by splenic Z score. At that point of time, we were not doing splenic stiffness in in the biliary atresia infants because of non-availability of the small probe. So, but next thing is to do the splenic stiffness also in biliary atresia. Beta blockers in biliary atresia. So one of the randomized control trial has been just finished and presented at ISBN 2 weeks back. Next thing is, can we reduce bile acids? So what is the concept of bile acids in biliary atresia? Bile acids are actually related to the damaged liver, because the liver is already cirrhotic. There is some obstruction which is going on. But this large multi-center study has shown that even if the bilirubin is less than 1.5, the serum bile acids actually act as a prognostic marker. So when the levels are less than 40 versus more than 40, so the outcome is different in comparison to, in relation to survival with native liver. So, but can we use ASBT inhibitors? So this is a trial by Myram using maralixibat in biliary atresia multi-center trial, but unfortunately there was no therapeutic benefit found and trial failed to meet the primary and secondary endpoints. So next is timely diagnosis. So I will just go briefly because this has been presented earlier also. So ultrasound, various markers, various imaging markers we have to look for. The meta-analysis have shown that absent gallbladder has a very good sensitivity, specificity, and also triangular cord sign. Stool color card tests have been used in different countries. In India also, one of the study from SGPGI has used stool and urine color card testing. So using stool color card testing, it also leads to early diagnosis and also improves survival with the native liver. So, but there are various differentials, and also the studies have shown that using stool color card also leads to decrease in the cost of overall management of biliary atresia for lifelong, and also it can increase the life years gained and also save the number of transplants if you use the stool color card. So this is a 12-point scoring system which was published in J Hepatology for 2014, based on clinical, ultrasonographic, laboratory, and histopathology findings. So various other markers like microRNAs, metabolomics, MMP7, and the bile acid, and even transient elastography. So various things have been used for diagnosis of biliary atresia, but these things are actually looking at biliary atresia, looking the fibrosis part of biliary atresia, not actually early diagnosis. So because already fibrosis is established, even if we look for either MMP7 or transient elastography, so these are indicative of fibrosis. So at ILBS also we have looked up we also looked up almost the similar which was published, a cutoff of around 8.5. What about antenatal diagnosis? Can we diagnose it antenatally? But this is a difficult thing to look for the absence of fetal gallbladder or cystic dilatation, but the sensitivity and specificity are low. What about low GGT in amniotic fluid? So this also is yeah. Yeah, yes sir. Yeah, yes. So this is one study where the bile acid. So this is actually for diagnostic, but the earlier study which I mentioned was for prognostication. So yes, sir. So diagnosis, actually this is only one study from China where they mentioned looking up the various bile acid different metabolites. So choledeoxycholic acid and the glycine conjugated deoxycholic acid. So they looked up a ratio of the glycine conjugated deoxycholic acid is to quinodeoxycholic acid. So they found that this has a good sensitivity, and they incorporated this ratio along with the GGT and clay stool, and they gave this equation, and this was found to have a.
Before the diagnosis by jaundice and others, what age were these children?
So this was almost around the standard age, around 6 weeks, 6 to 8 weeks. Yeah. ROC was better in comparison to the gamma GT also, and also individually to the clay stool. So when they and also to the individual ratio of the GCDAs to DCDA, when they combine these all three of them together, so then the bile acid, then this equation was found to be more helpful in diagnosing biliary atresia. So this is our breakup. The biliary atresia is still from ILBS data. So this is till around 2020. The structural causes, the biliary atresia was constituting around 45% of our infantile cholesterol, and the proportion is still same. So up till now we have seen around 850 to 900 overall cases of infantile cholestasis. So what about, so this is another data, so which was published, and again, so 13 cases were published on percutaneous cholecystocholangiogram, and now this has been recently compiled by Samannay. So where percutaneous cholangiogram was seen, and using this, we actually saved unnecessary laparotomies in 2/3 of these infants with pale stools. So usually it is said that when the infant is having pale stools, so they can directly go for perioperative, as is the policy in different centers, even in Japan. But with pale stools, there may be other causes. Like we found that other causes were PFIC, DCDC2, alleles, multifactorial. So we saved unnecessary laparotomies in these children. So this is just quickly going through this. So this was a late preterm who came to us from AIMS Jodhpur. So this was an infant premature with early onset sepsis. So the issues were prematurity with failure to thrive, jaundice, fluctuating stool color. Liver biopsy was inconclusive because this was done at 3 weeks of age. But percutaneous cholangiogram we did at around 45 days of age, which ruled out biliary atresia. So overall, and genetic testing was negative. So he was labeled as a multifactorial because of prematurity and sepsis, and subsequently jaundice improved. So next, and the second last thing is collaborate with pediatricians, neonatologists, and pediatric surgeon. And this is indicated by this work from Sanjeev Harpawat from Texas, that conjugated bilirubin even within first week of life. And subsequently, he showed that even at day 3 of life, the conjugated bilirubin or the ratio of direct is to total bilirubin. So the biliary atresia infants have higher bilirubin even in the first week of life. So the disease is not postnatal. The disease actually starts from the embryo. So we can pick it up very early. Now from the US and from the European centers, they are targeting to pick up biliary atresia at 3 weeks of age so that they can do early Kasai potoenterostomy. So last, cost effectiveness, they have, I think there is no, cost effectiveness has not yet been tested, because this was done in the retrospective samples. All the centers were called, and they actually looked up, because direct bilirubin they were not reporting, but he specifically asked and called each center to mention what was their direct bilirubin. So lastly is we should inquire and do research. So just to conclude, so biliary atresia is a lifetime disease, but using these strategies, using this mnemonic 9 points strategic, we can actually improve their outcome. We have to investigate and collaborate to further improve their outcomes. Thank you.